I'm here on behalf of myself and my colleague Julie Dick from Belfast, from the Children's Hospital. Julie, I know, has written an article for the TOFS magazine before about transitioning onto more textured food. She was invited to come and speak, but because I'm a London girl and I used to work in Luton, she said, why don't you go? So here I am. In Northern Ireland, we have a small population, 1.8 million, and only 8 to 10 TOF births a year. We in speech and language therapy don't necessarily see all of those children. Let's just start with why some of these children might have feeding and swallowing difficulties. Prematurity comes into it with some of the children which we have seen. The first TOF child I ever saw was born at 29 weeks. So when children are premature, they often have a long gap between the two ends of the esophagus and they can't have surgery very quickly. And therefore they may need something like a Repogal tube, which is a double lumen tube that drains the secretions from that blind pouch with continuous suction. And that means a long delay before you can think about feeding. Reflux is a very common issue, as you all know, and it's the most frequent complication cited for TOF OA, 25 to 45% reported, and can persist long term. And I know that there are joint European and North American paediatric gastroenterology guidelines, which came out last year, which cite these figures, and they've been a very useful reference for us. Tube feeding then is often the result with the prematurity, the delayed surgery, ongoing reflux, and chest infections. And multidisciplinary care is what's recommended. Because 47% of children with esophageal atresia will have direct aspiration or penetration. And it's been reported that 52 to 68% of coughs are associated with reflux events. So the airway and respiratory issues, which Professor Vyas talked about earlier on, are an issue for all of us as well. A number of the children will have laryngomalacia, where their voice box is floppy and collapses in. They may have laryngeal cleft, so that's a cleft at the back of the larynx, which can be from very tiny to quite large. Vocal cord palsy, which affects swallow safety. If your cords don't come together to protect your airway, you're at risk of aspiration. Vascular ring is when some of the major blood vessels press on the front of the voice box and can narrow the space. And then the tracheomalacia and bronchomalacia, the narrowing of the airways, can be quite significant. And this can result, as in Professor Vyas, some of his cases, in tracheostomy and ventilation. Some children may have esophagostomy. Long time since I've seen that, because we don't have a lot of TOFs. It's 8 to 10 births a year in Northern Ireland, where the esophagus is brought out through the neck and there may be sham feeding with a little bag attached so the child can swallow and then the feed comes to the outside. Studies suggest that 3 to 17% of those with OA may have vocal cord palsy. And pulmonary complications, as we know, are associated with reflux and can result in asthma, aspiration pneumonia, worsened tracheomalacia. And the joint European and North American panel recommended that anatomic abnormalities should be ruled out in patients with respiratory symptoms. The incidence of dysphagia was reported in a series of 10 groups of patients over 30 years, found to be 21 to 84%, but it's estimated to be more prevalent. It's known that children might not recognize their symptoms, and so it may be underreported. And the dysphagia can be ongoing over many years. 45% with dysphagia at 5 years, 39% at 5 to 10 years, and 48% at greater than 10 years. And symptoms are frequent in adults with TOF OA also. A number of our children with TOF OA also have syndromes. Some of them are trisomy 21, charge, and other syndromes. They may then have an absent swallow reflex, in coordination of their ability to suck, swallow, and breathe. Some of our children will experience fatigue and endurance problems because they may have underlying congenital heart disease as well, or chronic lung disease. And the big risk for us is oral pharyngeal aspiration, and I'll explain a bit more about the different types of aspiration. So I don't need to tell you as parents that feeding a child is full of emotions. We all feel when we have a child that one of the things we should be able to do is feed them. And when we can't do that, it's very frustrating, it's upsetting, it's distressing. And we can start to feel as though we're failing. And I've had a lot of conversations with parents where I say to them, it's not you, you're not doing anything wrong, it's him. It's him and all of his problems that's the issue. It's not you. So what can we do as speech and language therapists to help? Well, we assess clinically and we sometimes assess instrumentally, and we provide management. So when we do a clinical feeding evaluation, which is where we start, we take a detailed case history. It's really important for us to know all the medical background on the child because it all feeds in to the sort of picture that we're going to see and the kind of issues we might see. And often we get a call from a ward and we're just told that the child has TOF. We get down and review the medical chart and discover that they've got tracheomalacia, that they've got Down syndrome, that they've got 101 other things that nobody bothered to tell us about, which are all relevant. So we speak to parents, obviously, because they know more about their child than anyone else. We review the medical chart and talk to the nursing staff to get a picture of what's been happening with this child, feeding attempts that may have been made. We then observe feeding, and we start with something called state, even before we put a hand on the child, and that refers to how alert, awake, and settled the child may be. If a child is very sleepy, they're not going to feed. If they're very irritable and crying, they're not going to feed. So that's really important. How they respond to being touched and handled. Some of our babies, because they've been premature or because they've been through lots of negative events, don't actually like being touched and handled. So if when you go to touch and lift the baby, they scream, they cry, they get irritable, they desaturate, that's not a good indication for where you might go with feeding. We look at a number of oral reflexes, which are an indicator for us as to whether we're even going to try anything orally. And these are reflexes that are usually present from birth, so we consider if the child's premature whether they might be there or not. Some of the main ones are around rooting, so looking for feed, appearing to be hungry, alerting for feeds. We look at sucking to see if there is any sucking present, and there's a difference between the non-nutritive suck, which you would do on a dummy or a gloved finger, and then the nutritive sucking that you do when you've actually got to suck and swallow and breathe and coordinate. And we can have lots of babies who suck brilliantly on a dummy, but you give them a bottle or a breast and it's a whole different story. Obviously swallowing is very, very crucial. Some of our babies can suck, but the swallowing's not great. And if we have concerns about the swallowing, we may consider moving on to instrumental assessment. The picture on the left is something called FEES, fibre optic endoscopic evaluation of swallowing. It's not something that's routinely done in our hospital because it tends to show you before and after the swallow rather than during. And I know it's maybe used in some other centres. On the right is swallowing videophoroscopy, and this is more the gold standard. It gets to show you all the different phases of swallowing, and this is something that we do a lot of. So this is what a videophoroscopy looks like. And we're looking at the oral phase, what happens in the mouth, the pharyngeal phase, what happens in the throat, down to the esophageal phase. And the big importance for us is swallow safety. You know, it's not a good idea to encourage people to move on and feed a child who may be aspirating into their lungs. So that's our bottom line. It's got to be about safety. So we're looking to see if any of the feed penetrates, so tips into the top and comes out again from the airway, or actually goes down into the airway. And we look at risk factors for that as well, not just did we see it, but is their swallow delayed? Have they got material sitting in some of the little pockets in the throat after they've swallowed that they may then tip down into the airway? So that's what your oral phase looks like. So this is your palate, and this is the bolus of food inside the mouth. Into this pharyngeal phase, the palate lifts to close off so that you don't get food or drink into your nose, and the material starts to move down into the throat. So we classify aspiration in a number of ways. There's oropharyngeal, which is from the top down, esophageal through the middle. So sometimes the oral and pharyngeal phases of the swallow will be okay. Once the material gets into the esophagus, which isn't working very well because of TOF, OA, dysmotility, we can then sometimes see the material come back up and spill over into the airway. And then reflux aspiration from down below. So when we're managing infants, we start with looking at positive touch and oral stimulation. Some of our children are too small too premature to feed orally, there's a delay in their surgery and they're just not ready. So we have to encourage positive touch, because if a child is tube fed, they've got lots of negative stuff going on around their face and their mouth. We also look at cues around feeding, which is really important. If you've got a baby that's not in the right state to feed, they're not alerting for feeding, they're not showing an interest, they're not sucking their fists, that's important for feeding, particularly in premature and small babies. Positioning is important. This baby here is in a side-lying position. So he's lying across his mother's lap, head raised, and he's supported by her body. And this is quite a useful position for prems. Some children may need to be more upright because they reflux very easily during feeds. Some children will need support to their jaw and their cheeks to help them latch and suck. And a number of the children we will start with small volume feeds because they can't tolerate big volumes. It may help with coordination of sucking, swallowing and breathing. The endurance, the ability to manage a whole feed and not get too tired, and reduce the risk of reflux. We may recommend specialty teats and bottles, and some of our children need pacing, so they can't just suck. They get tired, they start to get uncomfortable, they start to get incoordinated. So we might say very, very strongly, 3 sucks, break the seal, or 5 sucks, break the seal, give them a break, start again. So with positive touch, we've combined all our resources recently into specific handouts that cover the whole area. We would have talked about desensitization before and oral stimulation, but we're calling it positive touch now. May involve body massage, touch around the face and the mouth, encouraging sucking exercises for the babies. So we start with touch. We may then move to flavour, which is liquid and no real volume, just dip and get a tiny little amount into the mouth. Moving on to taste, which would be maybe more of a puree consistency for the older children. Small volume feeds, starting to increase endurance and tolerance, and hopefully moving more towards full breast and bottle feeds for the younger ones, and then on to messy play and weaning, and moving on to textures. Messy play is important because it's a normal stage of feeding development that children go through, where they play with their food and they get into a mess. And if you have a child that hasn't fed in those early stages, they may miss out on this and become quite defensive. So you introduce food as fun, they help to become less sensitive, more comfortable and confident with food. And often if children are getting their hands into things, then they start to bring it more towards their face. You will have seen, I'm sure, some of your children don't like certain textures. Avoid messy play. They don't want to play with water and sand and all those sorts of things. They may avoid eating certain textures and be quite cautious, and may avoid taking food into their mouths. But it's worth being aware that there's a normal stage in feeding development which happens anywhere between about 22 months and 5 years, called neophobia, where children all are suspicious about food, don't like green stuff. My son was exclusively on a diet of kind of yellow-coloured food for quite a while. Drove me nuts because I'm thinking, I'm a speech and language therapist, I deal with feeding, and this boy eats chicken covered in crispy crumb, sweet corn, potatoes. Not a lot else, bit of yoghurt. But it's a normal stage. It's worth knowing that that happens. And it's also worth knowing that children need to be exposed to 10 to 15 trials of a new taste or a new food before they will accept it. So I've had numerous conversations over the years with people where I've advised them to make a change or try something new. They come back, how did it go? Didn't work. How many times did you do it? Well, once or twice, but he pulled a face. That's not going to work. So I don't need to tell you that you need to kind of chip away at this. It's a slow process, but you've got to kind of keep with it if we're going to make progress. So children can get stuck on puree, sensitive to the taste, the texture, the temperature of the food. Lumpy foods can be a challenge, and it can mean a new taste. And a tiny lump, a little pebble to us, can feel like a stone in a child's mouth. And moving on is easier if you take very small steps. So we recommend moving from smooth to bumpy to lumpy. And this is where Julie came up with this idea that we call the 90%, 10% rule. We found over years, if you said to people, right, you're blending the food, time how long you blend it for, do it a bit less to make it bumpy, That worked for a lot of children, but not for others at all. So she came up with this idea of keeping 90% of the food exactly the way you would normally have it, taking out about 10% and making that slightly more textured. And you give the child a number of spoonfuls of the very smooth, and then on about the 5th spoonful, just a tiny nip on the tip of the spoon is bumpy. And then you go back to the smooth. So you haven't changed their whole dinner. You haven't made everything bumpy and they're gagging and spitting and not taking it. And we found that this approach seems to work with our really resistant children. And you gradually then move to 20%, 30%, 40% being more textured. And then you can usually move on to the whole thing being a more textured consistency. What doesn't work? Forcing, coercing, bribing. If you eat that, you can have a slice of cake or some chocolate buttons. Distracting and disguising. And you know, the research is showing that these don't really work. And I know from my experience that the families I've seen who have pushed on and tried to force a child, we end up going 10 steps back that way, and we then have to start very slowly again, trying to move forward. Improving esophageal clearance. You see this particularly in older children. They self-select around food, so they know what's tricky. And they might not verbalize that to you, but they just avoid certain foods and they know what helps. Modifying the texture is really important. A lot of our children, because they've got really significant dysmotility, really can't manage some of the harder chewable foods, and we have to keep them on a more modified diet. There's a lot of work been done by the College of Speech Therapists, British Dietetic Association, Patient Safety Association around texture modification, advising that chewable pieces are no more than 1.5 centimetres in size for children to reduce choking risk. And choking is an issue with our TOF OA children because, you know, if their esophagus isn't working and they've got a piece that's not been well chewed, it can stick. So we talk about avoiding high-risk foods, pacing eating, and taking sips to help clear if there's residue building up. In Northern Ireland, we have put together on the back of the texture descriptors joint work advice sheets, and they cover the different textures. They explain how to prepare the food, and there are examples of the sort of high-risk foods that can increase risk of choking. And there's international work being done in this area as well, which is going to be rolled out quite soon. So, I'm just going to talk you through a little chap that I was involved with. He has a lot of the issues there that have been mentioned by other speakers. He also had cardiac issues. That's what the PDA, VSD, ASD is. Tracheomalacia, reflux, had to have a tracheostomy eventually. So he was diagnosed with TOF at day 2, had a very, very stormy early course. Lots of infections, pneumonias, significant reflux. Day 12, he had surgical repair of some of his heart problems. Following the TOF and the cardiac surgery, lots of failed extubations, significant difficulties trying to get him moved off ventilation. Ongoing DSATs, lots of respiratory distress. He was better when he was nurse side lying. There was a query if he had a peri-TOF pouch, but at 3 weeks he was diagnosed with severe tracheomalacia, and he had anterior compression of the airway. So he had more surgery. He then had a tracheostomy at 6 weeks because the tracheomalacia was so significant, and he required ventilation. He was eventually decannulated, had the trachea removed at 2 years and 8 months. He had ongoing retching after his NG feeds because of the reflux and was very agitated. We became involved at 2.5 months. No previous oral feeding. He was taking a dummy. He had taste experience. He was tolerating his oral care. So some of his reflexes were present, but not rooting and sucking. So we started on little tastes and advised sucking exercises. Between 3 and 5 months, it was really difficult to find a time when he was awake and settled because he was usually awake and agitated, or he was asleep. So it was really hard for us to kind of move on with him. Early swallow trials, no marked oropharyngeal aspiration, but when we did videophoroscopy, he was safe with tiny, tiny volumes. But he was nearly a year in hospital, mostly tube fed. and when he went home, taking what we call bite and dissolve, which is sort of foods that when you bite into them, they start to break down with your saliva. Things like What's-It, Skips, that type of consistency. A little bit of milky bar, tiny amount of yogurt, trying to self-feed. He liked his messy play, and we advised about the high-risk foods and easily chewed foods, and we were trying to introduce thickened liquids from a spoon because he didn't like cups. He was then re-referred to us for videophoroscopy at 3.5. He'd been fully orally fed by 2 years and 9 months, and he was on a moist, mashed diet and these dissolvable chewing foods. And the speech therapist locally had noticed a lot of spitting of saliva after clearing a mouthful. He failed to cooperate for the next videophoroscopy. That's toddlers for you. And then the next appointment was cancelled. And then when he did come, we noticed a number of issues. By this time, his mum had put him on thin liquids, but he really struggled with them. Okay, so this first clip, he is drinking. And you can see the drink yo-yoing up and down, which is not normal. And there's little bits tipping into the top of the airway here, penetrating. So that's not good. That's quite risky. Now he's taking some puree. He's got residue sitting after the swallow. And again, we scanned on down to look at what was happening in the esophageal phase. And we've got a stricture. A lot of hold up. And you can see how if you've got narrowing further down, the material will build up and then come back up again and cause issues. And if that goes into your airway, that's not good. This little boy ended up going for another dilatation, unsurprisingly, and we had to modify his diet until that could be done. And he has essentially needed ongoing stretches and very close monitoring of his diet. There were some issues at school, because I know Mum was in touch. They didn't seem to understand some of the risks and why he needed to be on a very carefully controlled diet, so that we had to have a lot of contact with the school to explain the risks and that there were safety issues, and it wasn't a mum being difficult and picky, because you do sometimes get these remarks of, well, this child is however old and they shouldn't just be eating puree. That's all they can manage safely. They have an esophagus that doesn't work very well. So now, for us, what next? We are running messy play, weaning groups with parents and getting their feedback on that to try and develop it further. We're hoping to run a joint clinic. We're quite lucky that we're all in the Children's Hospital together, the surgeons, the respiratory physicians, ourselves, ENT, and we can all link together quite well. We already have multidisciplinary feeding clinics and tracheostomy clinic, but we're hoping to have a more joined up clinic for these patients. So in summary, eating, drinking, swallowing issues are common. They can be ongoing over many years. Reflux and strictures are common. And despite dysphagia, high proportions of patients followed up long term are doing well with oral feeding. But the multidisciplinary team is vital. So each child is an individual, and detours are common in their journey.